Hey guys, my name is Jovan Romero. This is my complex case presentation. This is my title page, obviously starting out at Frontier Nursing University, and this is the Family Nurse Practitioner program. For this course, I do have Dr. Joseph McFadden, and this is at 700 clinical hours. I do have another screen here, so that's kind of what I'll be looking at as I talk. Starting out with the quick description of our patient and our subjective data. He is a 59-year-old male. He's Hispanic, Spanish speaking only. It's like 98% Spanish. He spoke very little English. And his chief complaint today is he's presenting for diabetes and a blood pressure follow-up and the management of those. His HPI he'll go by RA. He presents to the clinic for a routine follow-up regarding his diabetes and blood pressure management. He works long hours and days as a construction worker and is not able to regularly make or keep his routine follow-ups and appointments. He states that he's been taking all of his prescribed medications and denies any side effects from those medications. He states eating a typical diet of tortillas, rice, beans, and usually either steak or chicken, and various fruits typically throughout the day. He states that his wife has noticed that he has been snoring more over the past 6 months and that his sleep quality has been more poor, leading to feeling more fatigued during the day. His past medical history, he does have diabetes mellitus type 2, primary hypertension, and morbid obesity. He is married, he has 3 kids, he's a full-time worker, single income family. He drinks occasionally, usually only on the weekends or during events, no tobacco use, and he's never smoked. His father is deceased. He couldn't remember why. I guess his dad died when he was little. And then his mother is currently still living. She has hypertension and hypercholesterolemia. That was really the pertinent information. Moving on, continue with the subjective data. He has no allergies. He's currently on the following medications. He takes metformin 850 milligrams BID. He's on lisinopril 40 milligrams, amlodipine 5 milligrams, chlorthalidone 25 milligrams, and atorvastatin 10 milligrams. Starting with our subjective review of systems, he states fatigue that has worsened over the past 6 months. He's able to sleep but states waking up not feeling rested, multiple nighttime awakenings. He denies change in vision, denies headaches. Neurologically, he denies balance problems, denies peripheral deficits, denies weakness, denies peripheral neuropathies. Currently, he denies chest pain or palpitations. He states that, and with respiratory, he states that his spouse states worsening snoring at night, currently denies pleuritic chest pain, denies shortness of breath, denies wheezing or cough. Now, moving on to his objective data, his vital signs are this. He does have a blood pressure of 149/99, heart rate of 99, and SpO2 of 89%. He weighs 249 pounds, and he's 6'3". He's 63 inches. He's 5'3". And he has a BMI of 44. Goodness. His A1C was measured today in office at the clinic. It was 7.8, which was down from his previous 8.3. And getting into the physical exam, he was appropriately dressed and groomed. He was calm and pleasant, normal affect, no apparent distress. He did have a red light reflex that was intact bilaterally. Extraocular movements were intact. Oropharynx was without erythema, exudate or swelling, and he had a Mallampati score of 1. I chose to do the Mallampati just because of the snoring that he was stating. I wanted to see if his tonsils were swollen or enlarged, or if he had a big tongue, kind of just the factors for ruling out any possible reason for the obstruction. It was a 1, which is low grade or nothing, so his tonsils were nice and normal. Cardiac, he did have a normal S1 and S2. There were no murmurs, rubs, or gallops. He had a normal rate and rhythm. His lung sounds were clear bilaterally without crackles or wheezes, normal respiratory effort, and then usually intermittently as we were talking, you could tell he would stop and take a deep breath. But he was speaking in full sentences. He Peripherally, I noticed that he did have a +1 pitting edema noted to his bilateral ankles, and he denied pain when it was palpated, so it was non-tender. So starting off with my assessment, we'll kind of just work through. Each slide will be a little different, but his first diagnosis and his first assessment was that of primary essential hypertension. The code was I-10, ICD-10 code. Starting out with pharmacological treatment, this was kind of we wrapped our heads around which way would be more appropriate, and we'll get into that in the reflection part. But we wanted to increase his amlodipine to 10 milligrams since he was just on the 5s, and he would do that once daily. And this is in part due to the recommended guidelines for essential hypertension and blood pressure management. It's stated that essentially they want you to start your patients either on a low dose diuretic, typically chlorthalidone was appropriate, and he's already on it. And then start with either an ACE and ARB, which he's already on. He's on lisinopril, and then you would go to a calcium channel blocker. We want him to continue his lisinopril and continue his chlorthalidone. And then underneath there, you'll see that's the prescription. It would be amlodipine, 10 milligram tablets, PO once daily for hypertension, dispense 30 tablets and refill 1. We did the refill of just 1. That way, if he's not able to make it in right on the month, he at least still has medication so he can make his way in and not lose meds. Non-pharmacologic. We want him to do low impact, moderate intensity exercise 3 times a week. We get into this a little in the education part, but essentially I just explained to him that even just moderate intensity walking would be appropriate. And then we want him to start the DASH diet, which would include more lean meats, and getting rid of fried food and going on from there. And this is according to the guidelines. This is first line management. So we did spend a good little amount going over the DASH diet. We want him to monitor his blood pressure at home several times a week was appropriate. No referrals are needed. We did want to see him follow up in 1 month. Getting into the patient education, we want him to monitor his blood pressure regularly at home with a blood pressure machine. This will ensure appropriate treatment of his blood pressure and make sure that we're within range or at least getting better. Again, the DASH diet we went over, it's recommended that he eats fruits, vegetables, whole grains, lean proteins, less sodium and saturated fats and added sugars. So decreasing those, I know that kind of sounds like we want him to add more, but no, decreasing those. The intensity we went over with more of the brisk walks. We wanted his heart rate to get up, not just leisurely walking. And then we discussed that our blood pressure goal, we wanted to be ideally below 120, but we're shooting for below 130 over 90. And then because we're upping the amlodipine, we wanted him to assess himself and just be aware of the signs of low blood pressure, which were dizziness, weakness, syncope, or feeling like you were going to pass out. And then if these were to happen, he should either follow up with our clinic or seek emergent care. Moving on to the next assessment, that's of type 2 diabetes mellitus with hyperglycemia. So the ICD-10 code is E11.65. The metformin, we wanted to go up with it, but according to guidelines, it's also appropriate to start an SGLT2 inhibitor. That way we protect the kidneys a little more. So we wanted to stop the metformin, and then we wanted him to start Zig Duo. And the reason for this, we'll get more into the reflection, but so we want him to start Zig Duo, extended release. It's going to be 5 milligrams, which is the Farxiga, and then the 1,000 milligrams of the metformin. We want him to take that twice a day in the morning with meals, We're going to dispense 60 tablets and refill one. That'll get us through 30 days. Again, he's got the one refill if he can't follow up within the 30 days. The non-pharmacological treatment, this one kind of seemed like it was almost backtracking from what we just went over in terms of diet. But we do want him to eat a low glycemic index, which is overall reducing carbohydrate intake. We did go over this fairly extensively. He was really good at reducing his sugar intake. So he says, I don't really put creamer or sugar in my coffee, and I don't really eat sweets. But then, we went over the simple versus complex carbs, and it kind of clicked a little more for him. And then just keeping on with the moderate intensity exercise for 3 to 4 times a week. No referrals needed at this time. Follow-up is in 3 months, so we can recheck his A1C. And then we went over, this is our education. So our goal is that of an A1C below 7%. The recommended guidelines on this one were kind of different because there wasn't like a set number it said it wanted your goal to be. It said that it was essentially based off of symptoms and provider preference. So my provider likes his patients to be below 7. And then going over the Zig Duo, we did discuss that it's a dual combination medication, which has the SGLT2, which is the Farxiga, and a biguanide, which is keeping up with the metformin. So we are going up with the metformin and adding the Farxiga. We discussed that this would help protect his kidneys, and it does so by helping you urinate and void more sugar. That way you're reducing the overall circulating glucose. Continuing with the education part, we want him to keep walking. We went over the low glycemic index diet. Eating a low glycemic index diet, which we talked extensively about the carbohydrates in his rice, his tortillas, and his breads. Eating bread was a big one for him. And then we went over essentially a little more about the Farxiga. So it alone wasn't going, we know, and our expectations of it aren't to reduce and control his sugars alone. So we did go over that sometimes you might have to add other medications, but controlling blood sugar overall is a comprehensive thing, and it should include reducing the carbs in your diet, lifestyle modifications like exercising more, drinking more water, and then adding medications to help reduce your overall glucose. Alrighty, so our evaluation, just going over backtracking and seeing how we did here. So he does have, in specific with him, he does need some diet education. He was really good at understanding that sugars weren't going to help. Ingesting or eating sugars weren't going to help reduce his overall glucose. But he didn't understand the carbohydrate mechanism to it. So he just understood that sugars were bad and then everything else was fine. So we did go over some education, exercise education. When I told him that, we want you to exercise a little more, he was like, well, I work 12-hour days, 6-7 days a week. And we just went over that work exercise is awesome, keeps him young, keeps him fit, but we can always increase a little more, we can always just do a little more, and he was okay with that. He did say that he had family support. His wife was very supportive. She's usually who makes all of his lunches, and he said that he would go over just the simple things of what he wanted to try to get rid of in his diet. Another health need that I determined for him was that maybe a cost of supplies would be an issue for him. The big one was, we want him to check his blood pressure at home, but does he have a way to buy the blood pressure? So the facility that I'm at is an FQHC, which is a federally qualified healthcare center. They essentially receive grants from the government that help reduce overall cost of care. And we'll go over this a little more in the review part. But they do offer things like blood pressure machines and glucometers and things like that just to help reduce the cost. They do offer that to the patient. And then his language barrier. This one wasn't a big issue for me and my provider personally because we speak Spanish. But in the future, if he were to ever change providers or move cities or change the care, then that could be an issue for him. The overall outcome, he did follow up in a month as recommended. He was able to make an appointment and he stuck to it. His blood pressure did come down. It was 133/87, and this is with periodic checking. So he sat down. First one was like 138. So then they just did serial blood pressures over 15 minutes, and this was the better one after the 15 minutes. So 133/87, heart rate of 91, and his SpO2 of 92%. So that improved. An A1C wasn't checked here just because it had been the month. Going over it with my provider, he said we probably could have checked it and it would have ideally went down just because it is that average. So that average over the month maybe would have brought it down, but he wanted to just check it in the 3 months. He stated an overall improvement in health, but his big thing was he hadn't worked out or hadn't really walked since. That was his big, negative feedback with it. Were our goals met? So an improvement was made in his overall blood pressure, although we weren't quite at goal. As discussed, we did want him below 130 on the systolic, and then, in a perfect world, below 80 is the guideline goal. So he's not quite there, but he's working on it. Because of his blood pressure, where it's currently at 133/88, he still is in stage 1. So then the following here is just the guidelines per blood pressure and stages. And you can see that there. So stage 1, kind of working your way down there, is 130 to 139 systolic and at 80 to 89 diastolic. As discussed, his A1C wasn't checked in this appointment. And then I did switch providers at the clinic, but I was still at the same clinic. So I followed up with that provider, and he said he did come back in the 2 months afterwards, which was 3 months total, and his A1C was at 6.9. So ideally, he really is he's below that threshold of the goal of 7. He's still got a ways to go to be, perfect case scenario, but he's making an improvement. He did say he was a little frustrated with the amount of peeing that he was doing, but it wasn't an overall deficit or a deal breaker for him. And then there was really no conflicts. The provider I thought was awesome, and when we discussed this patient, between visits and afterwards, we were both on the same page with everything. So here's my big reflection. My biggest takeaway is that I learned that every patient has the potential to be complex and that there's not a one-size-fits-all method of treatment. The hardest decision was determining if increasing his amlodipine would be beneficial or if it would just cause more peripheral edema, leading to a need for an increase in his diuretic. So I guess our big dilemma was, do we increase the amlodipine, which is going to give us more edema, or do we just skip that and increase the chlorothalidone, which he was at 25, so he could go to 50, and maybe just get rid of fluid all the way. But because we did add the Farxiga, and it's not traditionally a diuretic, but it will help get rid of some extra fluid, we decided to up the amlodipine and then just add the Zigduo with the SGLT2 inhibitor. But yeah, it's always hard to decide what treatments needed attention first, specifically with a patient who doesn't follow up as needed. In this case, we recognized the possibility of sleep apnea, but we decided to treat his blood pressure first. So it was evident, we didn't just skip over the SpO2 of 89%. It was kind of one of those dilemmas of the chicken and the egg, right? Like, which came first? So overall, we decided to treat the blood pressure. see if we can control his blood sugars, leading to greater weight loss, which would overall improve, in a perfect world, improve his sleep patterns and improve sleep apnea if that's what he has. At the end of this initial counter, I wasn't quite confident that he was going to keep up on the regimen. He was really good at taking his medications from the get-go, but I wasn't sure if he was going to follow up. So it was great to see that he returned and that his blood pressure came down, and then a couple months later that his A1C came down too. As I kind of touched on earlier, the clinic that I'm at is an FQHC, so it's pretty cool. They're able to offer medications and treatment, labs, exams, and they're able to offer all these things at a lower cost, and they just do it all off of a sliding scale. And if there's an exam that they can't provide, then they usually just provide a voucher for it, which is, in a perfect world, gives patients still an opportunity to get seen and treated. But because of that, that's why we went with the Zig Duo. They have a list of medications that are cheaper than others. So the Zig Duo was more appropriate than like a Synjardy, and that's why we went with that one. And it was actually cheaper to have the Zig Duo than it was to just do the Farxiga and the metformin separately. So that was our thought process with that. I think in this scenario, this is just our reflection continuing. We were able to build trust with the patient by speaking in his native language, which I feel like made him much more comfortable. In the clinic, I would say 95% of the patients we see here are Hispanic, whether they're from all the different countries, but most of them are Hispanic. I feel like that made him more comfortable, and it was able to help him be more compliant in the plan because he understood it more clearly and there was really no gray area. I think sometimes when you use an interpreter, whether it's through an iPad or a calling service, sometimes things get lost in translation and they don't really translate perfectly. So I think it was great that we were able to speak to him in his tongue, in his native language. Overall, I feel confident in our plan and direction of care for this patient. I would have liked to address the hypoxia a little more, in retrospect. But going back, I was able to talk with the provider. We're really just a couple desks down from where I am now to where he sits. And he said that he did send him for an overnight sleep study to assess for his possible obstructive sleep apnea, and he was still waiting for the results. Overall, I imagine that as he continues to manage his diabetes and to lose weight, this should also improve his hypoxia and snoring at night, leading to an overall improvement in his health. The big thing I wanted to go over was our role of using AI in improving care. So at this clinic, I've noticed that most of the providers do use some type of AI. Whether it's Doximity or Heidi, those tend to be the two most common right now. And they all say that it's been pretty great. They say that it improves their time that they're able to spend with their patients, and it leads to less time charting between patients or at home. I also think it helps with accuracy. I've noticed many times that the AI software will pick up on subtle details such as time frame of an illness or characteristics. It also has an option to add recommendations such as therapeutics or imaging, but can sometimes mess up the names of doses of medications. And that kind of seems to be the downside of it. With that being said, it's great. I also feel that the integration poses a possible risk of developing lazy or possibly incompetent providers. I can't help but wonder if maybe some students eventually, maybe in the future, will stop learning because they recognize that AI can just find their solution for them. But thinking about it in retrospect, I wonder if that was the same thought process of when providers way back when had to use almanacs and books, and then we transitioned to most things on the computer. So I guess it just depends, and then it'll be interesting to see how that moves along in the future. These are my references. Thanks for being patient with me, and that was my patient.